like paranoid it's not recording. Okay, just a quick chit chat. I had a question on my last video, the number 3 rehab nurse blog, and I appreciate the question. And here is the answer. The question was asking to break down some delegation, time management, and disease processes seen in rehab specifically. So I'm talking about rehab nursing, specifically inpatient rehab nursing, but it does apply to other nursing fields. So definitely stick around and listen. And I hope this helps you. Thank you, the person that asked the question, but also other future nurses, new nurses, that have experience but are back in the field or in another specialty and are coming to rehab nursing for the first time. So we welcome you. I welcome you. And I hope that this helps. So I want to start out with disease processes, and I think that will help go into some of the other questions as far as time management and disease breakdown, because we're talking about your nursing shift, right, in an inpatient rehab setting. So this is, again, and I've said this I think in other videos, but I'll keep explaining it. So if we're talking about this is the hospital, then patients come to an inpatient rehab. It's like one tier below a hospital setting, okay? Then it goes to like a subacute nursing home, SNF, like skilled nursing facilities type setting. And then the next level of care would be like an assisted living type setting. And then there might be like an independent, but still like assisted, like you're getting meals and stuff, but you live independently, and then you might transition to the other assisted livings as you age. Or there's home, of course, being the goal for all the people, everybody to be out in the community and home, and then there's like home health services and stuff you can get at home. And then I would say there's obviously like me and you, like an independent person just living on their own with no services. So that's kind of the breakdown. And so we're talking about like sick patients, like just had surgery a few days ago, but still have other medical things going on, issues with their blood pressure, issues with their blood sugar. Maybe they need IV antibiotics. Maybe they need wound care. Maybe they're a little confused. They have a UTI, etc. So they send them to a place like mine, like an inpatient rehab facility, so that they can get stronger, or a fresh stroke. So that's probably like the top disease processes. So going back to the type of disease processes that I see and that you're gonna see, stroke being number one. And just with the population that we have, you know, health as well, all of that stuff, heart disease, stroke, diabetes, those are like high comorbidities and high disease processes that you're gonna see. So stroke, I would say, is number one. We see a lot of falls with fractures. So falls with fractures and falls with brain injuries, right? So then that includes like falls off ladders, people falling at home, breaking a hip, breaking multiple bones. So you're taking care of those people. Then you'll have, that kind of goes into like your brain injuries, because sometimes you take care of brain injuries, and it depends on where you work. Some rehab facilities specialize in some things. Some rehab facilities, you know, they'll specialize in stroke, they'll specialize in like neuro, spinal cord injuries, or traumatic brain injuries. You can get specialized in, I'm pretty sure, in like orthopedic too, you know, like with hips and stuff. But the stroke, the other certifications are very common. So yeah, we'll see falls with fractures, traumatic brain injuries. So that can also, that leads into my next disease process. So traumatic brain injuries can be from like car accidents, so that you kind of go hand in hand with like the orthopedic multi-complex cases, because it's a car accident, but they're also a brain injury. Which stroke is a type of brain injury, but stroke is in another category. you'll have the TBIs, you'll have spinal cord injuries, which also sometimes comes from motorcycle accidents, motor vehicle accidents. You'll get a spinal cord injury, and that's a category in itself, which some rehab places are, certified in the spinal cord injuries, which is cool. It's good work. Like, it's crazy sometimes what happens to people, and if you don't know someone personally, you don't kind of see it, and people like are kind of in shock, like in the care that we do and the stuff that we do. It's like, yeah, this happens to people, and someone has to take care of them. Someone has to like figure out how they're gonna live. You know what I mean? Like, they're not as acute, right? Like, the hospital saved their life. They were in the ER. They, had surgeries. They got like control of the acute problem, right? They were in the ICU. They were intubated for whatever amount of time until they could heal a little bit, and they rest their organs. That's why they're on ventilators and stuff. You know what I mean? Like, it's a whole process to get the body back. And just any moment, like any small period of time being down, being in the hospital, just laying in the bed, like the body deconditions so fast. Like, the body's amazing, and it compensates so good and so long. Like, it tries to really compensate for a long period of time for stuff that we do to it or stuff that's wrong, but it's a machine, right? Like, it's so many working parts, and it deconditions really fast too. So people get weak really fast. So they need the rehab. The body needs that repetition, you know what I mean, to get the muscle back, to get the strength back, to learn how they're going to be on their own. So imagine somebody gets in a car accident, they have broken bones, they have a brain injury, they have this whatever going on, infection, surgeries, they can't use their arm, they can't use their legs. So they're trying to figure out how they're going to maneuver at home, how they're going to work, how they're going to go to the bathroom, how they're going to eat, right? So imagine being right-handed, you break your right arm, you can't use it. You break your right leg, you can't use it. I worked with people that can only use one limb. Like, you can only use one arm. They can't use both their legs because they broke this area. They broke their pelvis. You know what I mean? Like, for real. And we have to teach them how to go to the bathroom, how they're going to live, how, you know what I mean? It's sometimes a long process to heal. So that's what we do. So that's just one of the things. So we're talking about spinal cord injuries. We're talking about fractures, multi-complex orthopedic injuries. Also, disease processes and other stuff that we see a lot would be comorbidities, right? So not only do they have to have, so this is inpatient rehab we're talking about, so they have to have certain qualifications. Sometimes they might be too high level. Sometimes just a fall with a broken hip isn't enough. They have to have multiple fractures and something medical going on, because don't forget, we have physician oversight, so every day we're tweaking meds. Every day we're adjusting orders, trying to get a new plan together, trying to get their pain under control, trying to have them eating better, so it's a whole team effort, an interdisciplinary effort with all the departments, which is really cool. Therapy, nursing, case management, dietary, it's really a team effort to get these people back home. So other comorbidities that you might see, because they're going to have the stroke and this, they're going to be diabetic with heart disease. They're going to be they lost their leg in a motorcycle accident, and they're this and that with infection going on, So you'll see respiratory pneumonia, respiratory issues, pneumonia, period. So it's like on top of their stroke, they're laying in the bed, they can't feel one side, this is a fresh stroke, a person that was fine yesterday. Now they're not fine. Maybe they had high blood pressure issues or something. Now they had a whole stroke where they can't move their arm, they can't move their leg. So oftentimes they're not breathing as good, they're not breathing as deep, they're not getting out of bed as much. So that's why it's very important to be on this routine. We get everybody out of bed, no matter how much assistance it takes. But that's what the documentation, that's a whole nother video, but there's certain documentation that we do to show progression and to show how people come in and to show how they leave with therapy and nursing, and how much help they need, basically. So, right, that's a whole nother thing, but that's how we get paid, and that's how we show, the work that we're doing, it's certain scores and stuff and certain documentation. But like, if somebody comes in with a stroke and they like need a lot of work the first day or at the beginning of their stay, there might be like a total care max assist, but then we're trying to get them to independence, or the goal is always to get them to their prior level of function, right? The goal is to always get the person to how they were before this accident or incident or whatever happened that got them in the hospital. So the goal is to get them home and back to that level, but sometimes it takes a long time. Sometimes they did have a massive stroke and it takes the body a long time to heal. It takes a long time for those like neural pathways to rebuild, you know what I mean? That literally the brain has to figure out new ways of doing things. So they might take a while to get back to a level of independence, or they might still need a little bit of help. Sometimes we do discharge to like a SNF, which is still like rehab, but just not as much. And they still get the rehab, they still get the care, but it's not as acute. The stroke's a little bit like further back. So we see that. So pneumonia, we see diabetes, I mentioned before, but a lot of people are diabetic. A lot of the population is diabetic. You see like this infection, the sepsis, so you'll see somebody with the fracture, you're doing wound care or something like that, and then you also are giving them IV antibiotics because they're on long-term antibiotics for sepsis. Or this is a recurring thing. They've had surgery already in the past and they had surgery again, to clean it out or whatever, and they're on antibiotics long-term. So you're doing wound care, you're doing the long-term antibiotics. They might have a PICC line, a central line, etc. So that's some of the comorbidities. I think the biggest ones that you see in inpatient rehab nursing. So I'll talk about them more, as we break down, but that pretty much is the ones that you see that I feel like I see most common. To get into the next topic that she was talking about, I think I'm going to go into time management, because I feel like delegation is a part of time management. You have to be able to delegate tasks and to delegate, like to organize stuff and have good time management to be successful. And that's anywhere you work. So in nursing, I've been a nurse now for 2024, like 13 years, 12 or 13 years now. So you have to, and I think about this, and I talked about this with my coworkers sometimes, because when you have the experience and you're there to like a more experienced level, or like, the goal is always to keep growing in your knowledge and keep educating yourself. Like nursing is always growing and having innovative new devices and innovative new things, and more research comes out about different ways to do things. Like you'll hear it all the time, like, oh, we used to do it like this, or da 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 da, like, oh, you don't do it like that anymore, because there's been new research or something happened, they realize that that's not best practice. So I feel like I don't know when that change happened, you know what I mean? Like I feel like I always ask questions, I always observed, like I feel like it happens fairly early on. Like you're always building your wheelhouse of knowledge in nursing, but I feel like once you kind of see the same things or see the same patterns or know the disease processes, know the body, like you can expect, you can anticipate and expect certain things in your workflow. So that comes with experience, and I feel like just keep asking questions, just keep observing, be in, what's going on, in the know of what's going on in your unit. If you're precepting, those are the days to jump in so that you can ask questions and you could be supported, you know what I mean? Like, you don't want to take it easy at that period, and then when you get on your own, you'll get into a situation you're like, oh my gosh, like, I don't know what to do. You still have resources, but you still want to try to figure stuff out on your own, you know what I mean? They say the whole, like, nurses eat your young stuff, and it's always been a thing, even when I was in school, and that was 13 years ago. It's like, now looking back, it's like, it's not like we're eating young, you know what I mean? Like, now, as I feel as a more experienced nurse, when there's new nurses coming in, I just want you to try. You know, I'm not going to do it for you when it's very simple things we're talking about. You know, you should be able to handle your group. You should be able to handle the things going on. Of course, I'm observing if it's really critical. Like, there's different levels to this. You know, if there's something really critical going on with your patient, of course, I'm going to jump in, you know, whatever. But there's levels to it. And that's exactly what I'm talking about delegation and time management. Like, I can't do all your work for you and all my work for me. So I think just the work ethic and, you know what I mean, has changed over time, and nursing has changed, especially after COVID. So I just feel like the dynamics on the units is very interesting. You don't see a lot of older, like, experienced nurses on the units anymore. I used to see older nurses, experienced nurses, like in ICU and stuff. Maybe there's a few now. Not as many. A lot of newer nurses are going into ICU and critical care. You know what I mean? I do think it's cool because every specialty has a certain type of personality that goes with it, because it's like the type of environment is, you know, if you do well in chaos and, you know, like ICU is chaos, but it's a different kind of chaos. It's like more controlled. The ER is chaotic, but it's a different kind of chaotic because it's not as controlled. You know what I mean? You have a little bit more autonomy. So, and then, like, once you stabilize them, they go on. So it's kind of just crazy how diverse and how big this nursing field is. And then even just with, like, online and social media and building a brand and all that, like, that's a whole separate video. But, like, nursing is just so diverse and such a big field. You can do so much with a nursing license, and you have job security. You know what I mean? Like, it's worth getting into for the job security alone. But it does also take a certain type of finesse. Like, it takes a certain type of person to do this work, because it is hard work. And if you don't like people, and if you don't, you know, like to challenge yourself, and if you don't like certain things, it's not going to be a good experience for you. It's not going to be like good work. And then it's going to show in your work that you don't really like it, and it's not really like, you know, that you're there for a paycheck, right? So anyway, that's a whole nother separate situation. But reeling it back in to delegation and time management. So time management, like, specifically, right? I'm assuming you're talking about, like, tips and tricks on the floor, practical things, you know, not just me telling you it's important. So let me break down a regular shift, and also, like, some tips that I would do for time management. You know, like, obviously you come into work, you start your shift, you are getting your assignment, you're figuring out who's working. You know, I always kind of peep the census, like how many people is on your unit. You kind of, like, at the same time as you're just focusing on yourself and you're looking at your assignment, you kind of have to look at who else is there with you. You know, you kind of have to know what resources you're going to have that day, what resources you're going to have that night. You know what I mean? That's another level up, but that's going to help you in the future. You know what I mean? Like, as there's levels, there's layers to everything. Like Shrek said with his onion, there's layers to that. Like, of course, when you're just first starting, there's so many things. It's so overwhelming. You can't worry about, like, this when you have to worry about this. You do have to build your foundation. So, you know, just get your report, you know your preceptor and stuff like that, and get started. But at some point, you're gonna level up, right? And you're gonna look and see, okay, like, I'm working with these RNTs, I'm working with this charge nurse, I'm working with these other nurses, because I need to know who I'm working with and who I can rely on. And you really need them, you know, and the shit hits the fan. So peep that, you know what I mean? Anyway, so you get organized. I have my own like report sheet that I use that I kind of use to rehab, because again, rehab is a specialty. Like, of course, people feel like they just come to work and they're just passing meds and they're just doing certain things, but in rehab nursing, your job is important, and your documentation is important, and what you're doing for the patient is important, and every, thing that you don't do, that gets passed along, is, it's just like, it's not best practice, and you always can do something better. You can always do something, to your 110%. But some days you're not going to have 110%. And we understand that. And sometimes it's like, I'm just doing this. I'm just doing my job, the bare minimum, passing my meds and stuff. But once you get better, you want to add to that and know a little bit more and do a little more and do a little bit better. That's the natural kind of progression of it. And that's how it should be. You should be getting better. You should be improving. You should be feeling better about it. If you have been trying different things and you still aren't getting it, if you still feel like stressed about coming to work, if you still have anxiety about certain things, I would switch it up, boo. Like, if you've been doing it for a year plus, I would definitely give it a chance. I would give your unit a chance. I would give whatever a chance. But like I said, if you're stressed coming into work, if you have to pray and not like if you have to pray, that's good. But if you literally have to pray for strength to come into work, come to your unit and see the people you work with, that's not the business, boo, okay? But anyway, going back to it. So I have my own report sheet that I use, but there's tons of report sheets out there on Etsy. You can make your own. I'm sure when you go to work, there's going to be other people there that have ones that you can use or that your place of employment uses. Whatever helps you, you know what I mean? For me, it helps me to have a blank slate, and then I'll write in report in black ink about my patient or whatever is going on. And then throughout my shift, I'm writing in another color. I'm writing in blue or purple or whatever. So if I'm there a few days with the patient, I know what's going on and what the trend has been a few days. Cause it's okay, well, blue was yesterday, today's green. So the blood sugars from yesterday, the vitals from yesterday, what I straight cat this person for this much. I had new orders for this much. We adjusted blood pressure meds. We adjusted pain medicine, whatever. So that's all the stuff that's written on my sheet. So like I said, I'll write in black ink, and then throughout my shift, I'll write in another color, and then I'll keep the sheet for the next day. And then if I'm off, then I'll shred them. So that's kind of how I work with my report sheet. And then in rehab nursing, there's other kind of things that stand out. Again, like I said, if we're talking about a stroke patient, they're getting up, they have therapy, maybe they have swallowing issues, maybe they need help feeding. There's sometimes multiple parts that go into it. So time management is important, and delegation is important, because it's kind of you have to stay on the schedule, right? Not only are you staying on the schedule of time with medications throughout your shift, because you have certain medication you have to give at certain times. You have meal times during the day. At night, they're sleeping, sleeping. I've worked nights. People don't sleep at night, just FYI. You would hope that they get some sleep. And for the most part, people do. They have pain medicine, they have sleep medicine and stuff, but people don't sleep. So you have the meals during the day, you have therapy. So it's you have to stay on the schedule, because you don't want to miss maybe their tube feed. You don't want to miss their feeding. You don't want to miss medications. You want to be on time, because all this stuff is helping them do better. You want to pre-medicate them for therapy. This is all included in your job, being aware of that. And that's what you're trying to get done during your shift. Maybe you have wound care, maybe you have education to do with them, discharge education, maybe you have an admission coming in, you're doing skin checks, you're doing wound care. So all of that you're trying and documenting it all. You're trying to fit in to your shift, right? And that's minus the time that you're doing all that stuff. So minus the 2 hours you're passing meds, minus the hour you're doing patient care, minus, the hour you're talking to families and stuff. So all that time, like in my brain, I consider like large tasks, like time consuming tasks. Like when I say that something is like acuity, like high acuity, where we're talking about something being high acuity, we're talking about a time consuming task. So we're talking about you being in the room for 20 minutes, 30 minutes, an hour, doing a dressing change, doing education or whatever. Changing a suprapubic Foley, changing whatever, doing a central line dressing, doing care. So if you're going to be in the room, you know, more than an average amount of time, I would consider that high acuity, and I would consider that, you know, in your mind's eye, something that you need to point out, that you need to make time for in your plan of the day. You know, you can't just, because as you're still planning, you're still having to adjust because there's still stuff going on in the real time. So not only do you have a plan, you have a plan that continually changes, right? So you have to be flexible because you have to be willing to change up what you're doing, but still know what you have to get done. It's really hard. And that's why in my last video, I was talking a little bit about that diner dash game. Like if you're in your brain, I feel like I do those games because it helps me juggle multiple things. Like my job is different every day. It's juggling different things every day for different people, trying to mark things off the list, trying to get things done. In my mind, you know, it's like I'm getting those points. You know, I'm getting those points in that game. And I'm helping, you know, the patient, and I'm trying to do my best to get them, oh, I'm sorry if I just messed up. I'm trying to get them the best care. I'm trying to get them answers to questions. I'm trying to get them good and stable so that they can go home, you know what I mean, and not get worse. We don't want to make anything worse. We always want to make stuff better. And my goal never is to like waste anybody's time. Like I feel like time is so precious, you know. I don't like to double work, and I don't like to waste time. So I feel like that's how I run kind of like my work shift. And when I was on the floor more, like now I supervise, so I'm like running the whole unit. And even before, I've done a lot of charge and a lot of supervision in my, you know, career. I got kind of thrown into management kind of early because I had a bachelor's degree. And I started out in long-term care, so I was like the supervisor very early on in my career in a long-term, you know, taking care of 120 beds for 3 to 11, be the only, you know, supervisor, the only one in the building at night taking care of all of these things. So I feel like I'm, you know, kind of like used to it. That's like my personality. I like to lead. I like to lead by example. I like to be a resource. You know what I mean? I like to use my experience for good and try to help others, you know, but also I'm not gonna like do all your work for you, and I'm not gonna like double work myself, you know, because people will let you do the work for them, you know what I mean, and not say anything, not think twice of it, just let you do 2 times your work and then just chill. So you have to have a little discernment and a little bit of like, you know, it's a hard like line to like shimmy down. But anyway, back to time management. So you get your report, you figure out a system that works for you. You always see your patients. Like you always start off the shift with laying eyes on your people, because again, you'll learn with experience that a change happens really fast. And if you didn't lay eyes on your people, you don't have a baseline and a reference point to go off of, right? So if you come in the morning and you get report and they're diabetic and they were sleeping, right? Like you didn't necessarily wake them up when you first started your shift. Sometimes that's okay, sometimes that's not okay. What if their blood sugar is low and they're almost like in a coma, you know what I mean? Because that's happened, I've seen it. And the nurse never laid eyes on, never like woke up the patient or like, you know, seen them like really move or assess them to know they're before this, of being more unresponsive type thing. Just always lay eyes on your patient. They fell. If you didn't lay eyes on them and know they were in the bed at this time or that time, or the last time you seen them, or you noticed them in the bathroom, but you never seen them come out, or sometimes you have to put the pieces together, and just that little observation, like, you have to be very observative. Just that little observation will save you later. So yes, all those things are important. So back to a work shift. So you lay eyes on all your people, make sure they're good. Like, they tell you that you're supposed to do walking rounds, because that holds the shift before you accountable. That again is another layer to your workflow. You know what I mean? Is once you get a handle on, your workflow, then maybe you can try holding your coworkers accountable. It's hard, but you got to just worry about you and your shift, and then you can hold other people accountable, right? So you see your people, you look at your MAR, your dashboard, you log in, get your people on your sheet and stuff, get organized, and usually there's a way to clear your board and see your orders and stuff, because that's important. You want to know what stuff that is left over from the day before that you need to add into your shift, and then you need to know what new orders and new stuff's coming in so that you can add it into your shift. You know what I mean? You might have a new order for a urine. The lab might call saying, blood is hemolyzed, you need to redraw this person. All that stuff is going on in addition to stuff throughout your shift. So you need to know when to stop and be like, okay, I need to do this because you're holding up other people. I need to stop and do this because the lab's waiting for me to do this. I need to stop and do this because I have to send this lab before I hang this antibiotic. I have to draw this Vanco chop before I hang this antibiotic. So all that stuff is, you don't want to hold it up, because then it's going to hold you up in the future. So as far as delegation, that's in my head, again, when you're talking about tasks, you delegate other tasks. You delegate tasks to other people, to the RNTs or to the charge nurse when you need help, or to another nurse when you ask for help. That's kind of how I feel is what delegation is. Everybody has a scope of practice. Everybody can do certain things within their scope of practice, and then usually it works up. So it's the person up here can do all the things in the scope of practice. The person here can do all of these things in the scope of practice, but they can't do this job. They might be able to fill in and do it temporarily and educate and find out more about it, but they're not really trained to do this job. They're trained to do this job and all the jobs underneath. And that's kind of the hard thing to wrap your mind around in healthcare sometimes, because if you're not looking at it from this perspective, it's hard to really see all the working pieces and all the things that are going into play. So it's you need to be able to hold down your group and what you have going on, because you're holding up all you're holding up, meaning foundationally you're holding up all of the other tasks and all this other stuff going on the unit. To the RNTs or the techs that you have. Then you have nurses, then you have your charge nurse. So it's the charge nurse can do all these tasks, but you got all these people can't help the charge nurse do her things. You know what I mean? So it's the charge nurse might do staffing for the next shift. The charge nurse is doing complaints, talking to families, whatever, education, following up on old charting that's wrong or whatever. So it's I could answer all these lights and do all these things for you, but there's a certain organization, a certain flow, a certain way that the unit is moving where I can't get all my stuff done if I do all of this stuff. So it's I need you to hold this part down so that the unit can flow better, and then everybody else can do their jobs, and then I can do my job. But of course, ask for help. You definitely have to speak up. Nobody's mind readers. You know what I mean? I think a lot of tension comes from people thinking, somebody else is supposed to do this, somebody else is supposed to do that. But it's did you ask them for help? You can't just assume that they're gonna know what you're thinking. Like, everybody has different things going on in their brain. Like, you can't assume that they know what you want them to do in the moment unless you ask, unless you say, like, I need you to do this, and they don't do it specifically. You know what I mean? Unfortunately, like, some stuff is obvious, but, you know, unfortunately, that's kind of how we have to run in healthcare. But I'm just like laughing because it's just crazy. But yeah, so delegation. So sometimes it's like hard. You can delegate up, you know, you can ask your superiors, ask your fellows too, but you can ask for help and with certain tasks that might be happening all at once, right? So say someone's pain pills due, and you also have to straight cast somebody, and you also have to hang an antibiotic and do a tube feed bolus at 8 o'clock, right? And breakfast, and people need help going to the bathroom, and people are getting up, right? Yeah, all of this is right when you start on your shift, and you have a patient who's like ostomy bags leaking, and you're gonna have to change it, the whole thing, the wafer and everything, right when you start your shift. So you're just like, and of course you'll have an admission, and that's not even, we're not even gonna go there, but just those things, right? So you start your shift and you see your MARA, you have antibiotics to hang. Somebody's calling for a pain pill. Somebody's ostomy bag needs to be changed. And there was one other thing that I said, and I don't remember now what I said. But that's all going on. So, and a tube feed bolus. You have a G2 patient that needs to be fed. But he's doing pretty good. He can do kind of it by himself, but you still need to help facilitate. Okay, I'm giving you a break there, right? Because that's usually not true. Usually you're doing it all for somebody that's a fresh G2, right? But anyway, I'm giving you a break. They're on their way out. They're discharging in a few days. So you have to do education. So you just really have to like get the supplies and set them up, and they can kind of do it, right? But you still have to chart it. Okay, but you'll have a straight cast, antibiotics, and that. So one thing that I feel like is top tier, high priority. You can't miss people's food. You can't miss their nutrition. That's a rookie mistake. And the first time you do that, you won't do that anymore. That's like not a mistake that you do often, because you realize how important it is and that you can't make it up. Usually in nursing, you can retime stuff, you can give a pain pill a little bit later, apologize, you know, you usually can do different things to smooth it over, to make it right. You know, talk to the doctor, like usually it's not usually that crazy, but you can't, like, meaning like when you do a med error, like if you miss a medication or if you like miss something, but if you miss somebody's food, you can't make that up. And I felt so bad the first time that I did that to somebody. Rookie mistake. Like, I was new nurse, I had so much going on, totally forgot that the guy had a feeding at like the beginning of the shift. So then of course when I realized, it's like he had another one due like at bedtime. So it's like I can't give him 2 now because he can't tolerate that much food, etc., etc. I could give him a late one later, but it's like, damn, I just missed the guy's food. And that's not something I can just make up. So they're not getting the nutrition that they need, you know, it's all calculated per what they, you know, need for their body weight and all that. So it's just like, damn, like I just felt so bad. And I never, ever, ever would do that again, like ever. It's always a priority. I always look at the orders. I get it in report. I'm listening, right? I'm listening like, okay, they're NPO, they're tube feed, they had a stroke, whatever. They're going home. We're doing education on tube feed. So that just, in my mind, brings me to that order. So I still look at the order. You can't go off 100% what you hear in report, but what it does is it brings your attention to certain things that are gonna help you through the shit that you're gonna have to do, so you don't have to figure it out late in the game, basically. So it's like, okay, thanks for the heads up on that. They're having issues peeing, you just took their Foley out. I'm gonna have to bladder scan them. I'm gonna have to do this, I'm gonna have to do that. So I know, so that's stuff that you can prepare and help time manage and prioritize in your shift. So it's like, she told me the wrong order, you know what I mean? So it's like I can't knock her too much. She fucked up, she didn't know what the order was, but at least she told me that there are 2 feeds, so I can look at the order myself and get my shit right and get my stuff right for the patient, right? So that's on that. So that's a high priority. Again, like I said, when I hold up other departments or other things, if the doctor asks for something, like that's high priority. I do that immediately. If the doctor writes me and says, recheck this person's blood pressure, what is this, like bladder scan this person, or can you help me find this, can you help me do this, like that's a high priority. Just like if I come into the room and I'm trying to give somebody meds, I'm trying to do care, I'm trying to do this, like I expect the patient to stop talking on the phone, stop talking to their patient, their family member, stop doing whatever they're doing. Like maybe the tech is in there doing something. Like it's not that my task is more important than yours, but I have less time to do all these tasks. You know what I mean? I have more tasks to do in this 12 hours. So if you don't mind, please, appreciate you. I need to come in here and do your dressing change real quick, do your IV antibiotics, do whatever, right? Like some people don't like to be bothered. They'll give you attitude, like meaning the patients, because you know you're interrupting this, you're doing that. And of course, like don't agitate people. Like again, there's a certain finesse to it. Like, yeah, you're in the hospital, yeah, I'm gonna do whatever I need to do, I have a doctor's order, but also I'm not trying to agitate you. I don't want to escalate the situation. Yes, I can come back. Yes, I can reapproach. You know what I mean? But ultimately, like, I have all these things to do. So please, while I have a chance, while I have the time, let me take you to the bathroom now. Let me do this care with you now, so that when I'm doing the next care with the next patient that I have to spend 20 minutes with them too, you're not calling me back in here to do this, that, the other, right? You understand? So constant, that's your whole shift. That's your whole shift. Making a plan, getting interrupted, making a plan, getting interrupted, interrupting your plan to do something else to take care of this so that it does not escalate into something, you know, else. That's your whole workflow. And I think that's why I like nursing, you know what I mean? It keeps my brain going, even though I forget stuff all the time. Like there's certain things that I do, like I literally have like a stack, or like my desk will be crazy because I literally keep sticky notes, I keep reminders to do things, to chart stuff. I like write open boxes on my paper. I highlight stuff, I put stuff in bold and other colors to stand out to me, like allergies and stuff. So it's like you do whatever you have to do so that for you to be successful, and help you remember and help your workflow. So that all is with time management. Like I have so many pens and stuff just because I'm weird and I love school supplies and stuff, you know, not in school, but still go school supply shopping. I don't know. I feel like it makes me feel better. It makes me write better. So boom. So that's why I do it. Whatever you need to do, whatever makes you feel better, like whatever makes your flow better, like do it. And that's my top recommendation, you know? So also a tip for delegation that I would say is, and I don't know how long I've been just yapping over here. It was supposed to be like a quick chit chat video, but I hope that you're liking the information that I'm saying. I am dropping pearls, dropping teas, dropping gems. So this next little tip is you have to have a good relationship with people that you work with because they help you, right? So it's like, if you're in a room, you want your other coworker, your other nurse to hear your IV going off and not call you and be like, your IV is going off in 2, when they see clearly you're in 8 doing patient care. So it's like, okay, I'll be right there after I'm done with 8, I'm in the patient's room, but it would be nice if your nurse coworker would just go in there and turn off your IV, right? At least for the patient, because they're calling because it's beeping. But also you, as a nurse, prioritizing your time management, your delegation, I wouldn't be in another room for 20 minutes when I know my IV is going to go off in 2. You know what I mean? That also not better. I'm like trying to think of, it's like that is time management. you know exactly when your IV is going to go off, right? Like, I know when I hung it. I know when it's going to go off. It should be going off right about this time. I'm not going to go on break. I'm not going to disappear. I'm not going to be in another room for 20 minutes, most likely. Unless they call me in there and I get stuck in there with like an explosion and a big brown cow and it's unexpected, right? Otherwise, I'm not going to go and do like a planned activity when I know my IV is about to go off. I'm going to put a setup there. I'm going to leave I'm like, you're not really supposed to leave some, the saline flushes and stuff in the room. It's a medicine, all that. But I would leave a saline flush in the room, alcohol swab, and a cap right there so that my coworker, nurse, whoever, can disconnect it, and the patient will have to sit and listen to the beep though if I do get pulled into another room. But most of the time, you can also set the pumps, so utilize your resources, right? As in like the equipment and the people. I usually set my pump so that it's not going to beep. I usually have a flush bag attached to it so that it's not going to beep. It's going to run slow at 10 cc's an hour just to keep the vein open or whatever, just enough so I can get back in there and disconnect them. Or they have another antibiotic too. So I used to work night shift, and you didn't really want to keep waking up the patient like that all night. Sometimes they get 2 IVs, pretty frequently. Like I'm giving 3 or 4 IVs, basically 4 bags during my shift. So it's like, I want to hang the piggyback, hang the saline bag, have it all primed and ready to go. I don't even disconnect the patient. I want to make it as time, like less time, as least amount of time in the room as possible. I scan the patient, scan the med, I'm quiet, it's dark, you know what I mean? I have my little flashlight. I have like a little flashlight when I used to work nights. Then it would be like white or red, like different colors, like low light. So you can see, but you're not like waking up the patient. And again, I set that plan up with the patient early. I see them early in the night, I give them their medicine. So it's like, okay, I'm gonna be sneaking in about 12 to hang your antibiotic. Don't get alarmed, don't get shocked when you're sleeping and I kind of wake you up a little bit. It's okay, like leave your arm out. I'm gonna scan your bracelet. I'll scan the meds and just hook it up real quick. You won't even know. And that's how I did it, because you want the patient to try to be able to sleep, but also you have to get your work done. So that's like something to be aware of. Also, you have to kind of do a little bit, like it's give and take. So with your RNTs, with your techs, I think I know a challenge sometimes with people's workflow is delegation, right? Delegating tasks to the aides, to other people on the floor to help, as in like taking people to the bathroom, toileting, so on and so forth. But you have to be smarter than a 5th grader. You know what I mean? You have to be smarter than them. You have to, not smarter than them, but like you have to like know the personality of the person to like get them to do what you need them to do, and also reward good behavior, right? Like children. I don't even have children. And I learned this very early on, like having a good rapport with my people that I'm working with and like the techs on the floor, because they can make your life hell and they can help a lot with your workflow and your job. So it's like you need to work with them, don't work against them, but also utilize your resources, you know what I mean? Like work up the chain of command if you really have issues with somebody, but also like answer their light, do a little, give a little, take a little, so that when you're in a room, they're toiling your person. When you ask them to do something, to like stock a room, put like briefs in the room for somebody, if you ask them to empty a colostomy, if you ask them to, double check, did you empty so-and-so's Foley, did so-and-so pee, you know what I mean? Then there won't be any issues. I think a lot of times we forget that we're looking for different things when we go into a room, right? So like if a patient comes in the room, or if I go in the room and I'm giving meds and they have to go to the bathroom, of course I'm gonna take the patient to the bathroom. You know, most of the time it's not that hard, but sometimes it is hard. Sometimes they're already incontinent. Sometimes there's no supplies in the room. So I literally say that to them. I said, yeah, 15 had to go to the bathroom. They were already incontinent. I tried to change them, but there was no supplies in the room. So 15 needs to be changed when you get a chance, please. You know what I mean? But then earlier in that night, I took so-and-so to the bathroom and I put grandma to bed in 4. You know what I mean? So you have to do some give and take. But that was because I like grandma in 4. She's pleasant. I had to give her meds anyway. It's fine, you know? So it is give and take. But also, like, you have to know their routine so that you can, you know, kind of work with them. It's like you don't want to work, again, double work or work backwards. Like, if they're going in to change a patient, you have to do wound care on that patient. If they're incontinent, don't double work, meaning you go in after they already changed them, like, meaning like long after they already changed them. You want to go in with them, let them change them, do the wound care. You don't want to have to go in, they already were in there 2 hours ago, or, you know, they are still a few rooms away and you're there and you have to change this person all by yourself and do the wound care and everything. You're in there for like 40 minutes, you know? So I feel like that's delegation. That's more like the type of, you know, things that you see, asking them to recheck vitals, asking them, you know, to make sure so-and-so ate, if they can have another snack, if they can have whatever. Like, that's the communication back and forth, making sure you know that someone's thick in liquids, or like, you know, fluid restriction. I'd be like, don't worry about giving water to this person because they're on fluid restriction. So those type of communications should go both ways and should be open with your techs that you're working with. And I encourage you and behoove you to form good relationships and try with them. Try to figure out what makes them tick. You know, you don't have to kiki and laugh with everybody and like ask them, you know, their whole life story, but you have to have a good relationship with them at work so that you guys can work together and that you guys can do the best for the patient. So I'm getting parched, I'm getting dry here. I don't know how long I've been talking. I'm not sure if it made any sense, but this was just a chit chat to answer again that question that was on my last video about disease processes and inpatient rehabilitation, time management, and a breakdown of delegation. So I hope you enjoy it. I hope that you guys come back for another video. My next video, I think, is going to be about my plants. I did a little plant tour, a little plant house tour. So I'm going to edit that, and I think that one I'm going to post. So I hope you guys have a good day. Stay sunny, stay bright, and I'll talk to you soon. Comment, like, subscribe, all of that, and let me know what you want to hear next. Let me know if you're in inpatient rehab. Let me know your specialty. Let me know what part of the video you helped. What part of the video helped you. I feel like it's so crazy. Like, now that I'm like I'm in a supervisor role, I have to like lead more meetings and like talk to more groups and stuff. So I literally fumble over my words all the time. I feel like I think too fast. Like, I think about what I'm saying before I'm gonna say it, and then it doesn't come out right. It literally, I feel like, and then I'm like, what the fuck did I just say? Literally, like, just that fast. The brain is crazy. And then I'm like trying to fix it, but then I'm like fumbling over my words, and then I have to like stop and be like, what the fuck am I trying to say? All in like a second. It's crazy. Drop a purple heart emoji if that happens to you. But anyway, thank you for being here. I hope you have a good day, and I'll see you soon.